Now, you guys know I love chatting anything to do with health, and I'm so looking forward to talking to my next guest today, Jamie Martin-Smith. He is a plastic surgeon with the Mater Private. And you know what? Once we hear plastic surgeon, straight away, we kind of think the aesthetics and the cosmetic and the boob jobs and all of that. And while he does all of that, absolutely, he specialises in breast reconstruction after cancer as well. The techniques and the technologies have become so evolved in the last 20 years. I cannot wait to chat with him today, and I can't wait for you to hear it. Jamie, great to have you in the Are We There Yet studio.
Yeah, thanks for having me. It's exciting.
Yeah. So listen, we had Lorraine Walsh on not so long ago, and she was talking about working in the Mater. So you specialise in breast surgeries, in breast reconstructions as well. So we're going to get into all that. But first of all, give us a little bit of background, yourself, your training, and why you wanted to kind of specialise in this area.
Did the very straight pathway, leaving cert, went to college in Dublin, and then I got the points for med school, standard med school, training in Ireland, lived in London for a few years for sort of subspecialty training. Takes 10, 12 years, and then came back and got a consultant post in Beaumont Hospital. So my my HSE job is there, and then also work in the Mater Private. And I'm a normal person with wife, 3 kids, dog, the usual, tick all the boxes.
What's the dog's name?
Dog's name is Nala.
Nala. Oh, what sort of a doggy is she?
Well, she's like a red lab. So
okay, gorgeous.
Kids named her Nala from The Lion King.
Oh, love it.
So the days are full of plastic surgery during the daytime, kids in the evening, and then late night walks with the dog.
Yeah.
By the time you do that, it's
just to try and de-stress.
Yeah, pretty much.
But for someone, when you say plastic surgeon, it does have this connotation of an extremely important job. Generally, when I think of a plastic surgeon, somebody that is much older than you. I don't know if that's fair enough to say.
Yeah, you can if you like. I mean,
Because you're in your 40s, early 40s?
Yeah, 42.
Yeah.
So plastic surgery is, so we deal with mainly reconstructions. So if there's a hole, generally we fill it. Okay. Comes from the Greek word plasticus, which is to mold. And so anything that needs to be put back together, generally a plastic surgeon gets involved.
Okay.
And then that stems on to then, if there's a big defect in the skin, we got to replace the skin. So we do an awful lot of skin surgery. And so therefore that then leads on to, cosmetic surgery and trying, improve scars and improve closure techniques and stuff. So it blends into the cosmetic surgery, which then takes over all, breast, abdomen, face, and all those different things. And then the reconstructive side of it is, we usually go in after a cancer surgeon, either at the time of the cancer operation or at the time or later on once the cancer is completed.
Okay.
And then the last avenue is trauma. So if you lose something, oftentimes we're quite involved in the reconstruction or putting it back together or reconnecting.
And when you were a young med student, did you know that this area, this plastic surgery area, was the way you
didn't
wanted
even
to go? Had the clue?
I flunked the rotation. I went in and I got asked this question, really hard question, like the layers of the one layer of the skin. It's utterly ridiculous question to be asking a med student. I didn't know, so I got sent off the library and said, "Don't come back till you know." And I came back the next day, I still didn't know. I got kicked out. And so it was never on my horizon. And then you do basic surgical training, maybe year 2, year 3 of training, and they, you go through your different rotations. And I hadn't put down plastic surgery at all, but one of my buddies had put down a really good scheme, and he got it in front of me. And he jumped out, and he's a consultant in Harvard now. Anyway, he left. I took his job, and then plastics happened to be on it. And then first list I did, the consultant, the guy in St. James's, David Orr. The operations on it were a hand operation for Dupuytren's contracture, so he's operating the hand. He did an ear setback for prominent ears, and then he went straight into the abdomen and started messing around the bowel. And I was just like, whoa, this guy can do anything. And it was a real light bulb moment that there's this specialty out there where you could be anywhere on the body at any different given time of the day. And from there it just went on.
What was the first surgery that you ever did?
Actually, I know what it was. It was not a surgery, but I was an intern and I was doing orthopedics, very first job. And as an intern, you hang out in the wards, you just make sure everyone's alive and you do the paperwork. But I got brought to theatre one day and they were doing just a knee scope. And then the reg said, "Yeah, Jamie, you stitch that up." And I never put a stitch into anything. And I just remember coming home buzzing. I put in like 3 stitches. And I was just like, came home and I was just like, that was class. So it's funny how you just stepwise through your career, you just do bigger and bigger things, and you get a different kick out of different things.
Yeah.
Which that was probably the first one. Yeah.
But is it fair to say now that you're specializing mostly in breast reconstructions and breast surgeries?
Yeah. So like, look, as part of the HSE job, you got to look after everything. So I do hand trauma, nerves, tendons, bones of the hand. I do, reconstructions of legs after car crashes, things. I do an awful lot of skin cancer. So everyone's got a lump or a bump. Everyone who gets older has a little bit of skin that needs to be taken off. And that's part of the general workload of the services in the country. But then all of us have our thing that we love doing. And so you try to deal with all the other stuff quickly and efficiently to give you time to do your thing. And yeah, my thing is I do an awful lot of breast, which leads down both avenues, reconstruction and cosmetic, because it's the same. Because if you reconstruct a breast, oftentimes the other side needs a lift or a reduction or an augmentation, and that just feeds into, doing cosmetic breast.
And do you come at it differently emotionally if you are doing a reconstructive surgery as opposed to an aesthetic surgery?
Emotionally, probably not. I guess I would, like, the reconstructive side is a very much a factual chat with a patient of what can and can't be done, and like how we can make it better and what the patient's up for and those kind of things. And so I think, my cosmetic consultations are very similar in that, it's not a sell. It's I kind of look at the patient and look at the patient's body and do an examination, and we chat about it, and it's like, well, we can do this or we can do this, and if you do that, you probably will get an average result. And it probably does actually. You just have a more factual conversation, which I think actually most patients really want. Like, nobody's there for, to be sold something. Most people, like, wouldn't be hugely into like social media or these kind of things. So most of my patients are word of mouth or there's different Facebook groups and stuff, and my name pops up. And so everyone who comes into me has a fair idea that I would be more, I'd say, relaxed and approachable maybe in my manner. Yeah. Which makes for a good chat.
100%. And you want somebody that you can kind of have that chat with and feel comfortable with, because like, not only are you dealing with women in a lot of cases who have had a cancer diagnosis, the shock probably of cancer diagnosis coming into you. So women that are vulnerable and also wanting to make sure and wanting to be reassured that they are making the right decision, whether it is a reconstruction after a cancer diagnosis or an aesthetic requirement that they feel that, that they would feel more confident on the back of. You emphasize and talk a lot about the tissue reconstruction. We're going to get into that in a little bit, because 20 years ago, and I'm just going to be really honest, like when myself and a couple of my friends were seriously thinking about getting a breast implant, a boob job.
Yeah.
And it was all it was back in the day was the implants, the silicone implants. There were saline implants before that, silicone implants, but there was nobody talking about tissue implants. So this would have been kind of 20 years ago. Certainly that I don't remember. I went actually to get a consultation to get a boob job and chickened out in the end. So I'm really interested to kind of find out more about the tissue work that you do.
Like, the tissue thing all comes from reconstruction. And so essentially, I guess to go back on your first thing, patients come in, and if you have a cancer diagnosis, I describe it to them, you're almost like on this train. You're meeting an oncologist and breast surgeons, everyone's telling you what to do. And so when they come in to meet me, we do try and stop it and say, look, you can do whatever you want here. I mean, the quickest, simplest operation here to get you through your cancer is mastectomy. You don't need me. And so the only reason we do anything here is if you want it, and if you want to take this on, you want to take on a bit of risk. More surgeries, more risk, but also if you want to do something to try and put things back together.
And can I just jump in there? So like, let's stay then with the cancer diagnosis. So if a woman has been diagnosed and the breast surgeon has to operate on them, when do they come in and see you? Like, does that happen within the couple of days that they've been given the diagnosis?
It sinks in. Breast surgeon refers to me. So there's different types of reconstructions. Essentially the nuance is a mastectomy or removing the breast leaves most of the skin. And so all you have to do is put a filling in there. It's just volume. And we just have to choose what volume to put in. And the volume can either be a silicone implant, which, as I say, is like mentally and physically free. It's off the shelf. You just take it out, you put it in there, it fills the breast, and it gives you a shape and a size in a bra, and you can wear most of your clothes, and it looks pretty, reasonable. But like, your breast is so many different shapes. An implant can never be that shape. And so it's always just a prosthesis inside the skin. But that's one option. The other option is you use your own tissue. And to use your own tissue, I got to cut it out of you. I got to take it from somewhere. So that's a scar, that's a recovery, that's, small chance maybe it doesn't work or something like this. But that's like a big sacrifice. And so I use this word sacrifice the whole time, that if you're up for it, yeah, it's brilliant, because then you put in own tissue, you keep all the breast skin, you're literally just putting in a new filling, and you're swapping out breast tissue for fat. It's like a perfect switch.
And is it literally you just take a piece of fat from the tummy or the butt or the thighs or whatever,
Pretty
and
much.
you literally just layer it onto the...
It's got to come in a blood supply. So there's zones and areas in our body that have known blood supplies that I can dissect down the blood vessels, get a length of blood vessel, cut it, disconnect it, and then go into your chest and reconnect the blood vessels. And so that's the nuance of it. And there's maybe 4 or 5 good areas in the body to take it. But the best one, classically, your breast cancer patient will often have a few C-section scars, often had a few pregnancies, and therefore there's an excess bit of skin. Or like we're all in our 40s and 50s, we all get a bit of a belly. So there's always a little bit of an excess there. And so I always tell patients the sacrifice is different for everyone. So if you're like super fit, 6-pack, means massive sacrifice, but you can still do it. If you had,
obviously much harder to harvest the skin from there.
Harder recovery from them because they're tighter. They don't have that excess skin hanging down. But, the way, if you think about a pregnancy, that's how a pregnancy works. It slowly stretches the skin to accommodate. And so it's the same with me. If I steal it from a flat tummy, it'll slowly stretch to accommodate.
Right.
And pretty much always people have everything settles down eventually. It does take some time if they're much tighter. But yeah, so the sacrifice to everyone's is higher. Whereas if you've like 4 C-sections and you had 3 sets of twins and, then you lost a load of weight and you have all this excess skin there, well, then it's like a freebie.
Perfect.
Yeah, you want rid of it and I want to use it for here. And so everyone's different like that.
But I'm just trying to imagine if it was me going into your clinic and I've just had a cancer diagnosis, and all of a sudden then you're trying to make a decision on whether you have a reconstruction at all, have an implant reconstruction, have a tissue reconstruction. Like, it's a lot.
Yeah,
it is a lot to try and take on when you've just, your world has just been turned upside down.
And for that reason, some people don't. Some people come back to me a year later and we do it at a later date.
Okay.
But the point is, you see a breast surgeon, you see the breast care nurse, you hope you have your family there. You usually go home and try and debrief with the family. But a lot of women then have a very definite feel for it. As in, no, I just need to do my cancer stuff here. Get me in, give me a simple operation as quick as you can. Because obviously logistically
just
as
get
well.
the cancer out. That's all I care about.
Do a simple operation. I'll see a reconstructive surgeon some of that stage. And other people just can't imagine the idea of waking up, missing one side. And it's like, that's just like the biggest fear is that they would wake up flat on one side.
Yeah.
And so for them, it makes much more sense for me to be involved early.
Yeah.
And like, that's just a personal preference. And I don't shape that.
Mm-hmm.
And the breast surgeon in theory shouldn't shape it. They should just decide if they feel it's oncologically or cancer safe to take on that extra little bit of surgery.
And if you have your tumor taken out, you've had your breast removed, right?
Yeah.
And depending on the course of treatment then that your doctor is going to go through with you, whether it's radiation, whether it's chemotherapy, does that then impact what reconstruction a woman might opt for?
Yeah, for sure. Because, we talked about what you need is just the volume for a breast. But if there's a issue with the skin, so say like the skin is quite involved with the breast cancer and that's been taken away, or you have radiotherapy, which in general it just damages everything in the field, including the cancer cells, but it does damage the skin as well.
Okay.
That skin then generally doesn't tolerate a reconstruction, as in it's not stretchy, and a breast has got to be mobile, it's got to age well, it's got to droop a little bit with time, and a radiotherapy skin really doesn't do that. So they generally need skin imported, as in taken from somewhere else.
Okay.
And so the skin is better if we put the other skin in.
Okay.
You can put an implant under radiotherapy skin, but it'll always be this kind of rigid thing sitting high on the chest.
So is it not better then to have your radiotherapy, have your radiation and get it done and dusted and then go for the reconstruction to figuring out?
But the thing is, like, a tummy or own tissue reconstruction is pretty resistant. So having a big lump of healthy fat in there when you get the irradiation seems to mitigate some of the damage.
Wow.
And while it does tighten a little bit, not really to the effect that we care a huge amount about.
As opposed to an implant, can you have an implant and then have radiation? Will it change the shape of the breast?
For sure, but there's a really high chance you'll get either contracture or a shape change. And sometimes that shape change is totally acceptable. As in, let's say, the implant was down here, a little bit droopy, got a little bit tight, and now they're slightly off, but in a bra, they're the same. So that's a super simple operation. Patient gets a reconstruction immediately with no sacrifice. It's not a bad thing. It's not as good a reconstruction, but for some people, that's easy, and that's the right choice for them. It depends what they want out of it.
Yeah.
Like, do you want to be wearing like a no support bra, or do Do you want to be able to wear, like, I had a lady in last Friday and I was doing little adjustments on her reconstruction, and she said in a silky slinky.
What do you mean reconstruction? What do you mean tweaks on her
she
reconstruction?
had a breast reconstruction.
Yeah.
And then there's always additionals. So, the other side might need a lift to match it or a little reduction. So if someone comes in with a huge breast, I don't make them a huge breast. I make them what they want.
Yes.
Or if they're very low, make them what they want, and then we match them.
And then use just the other size.
Correct. And that's where the kind of crossover aesthetics comes in.
Yes, yes.
But oftentimes I'm making a nipple, doing a nipple reconstruction, or I can suck out some fat from the kind of the love handle areas and inject it in here just to improve the cleavage and do all these little things. So they're all kind of like additions that I do at a second stage. And she was saying there was one little crease here, and it was a pretty good reconstruction. I was quite pleased with myself. And she was saying, yeah, I was just wearing this kind of silky gown with no bra, and I could see this little divot. I'm like, well, like, we're doing pretty well here. She went from flat to a reconstructed breast. And I encourage this kind of chat. I'm totally okay, because I'm like, that's cool. I can fix this little thing. But
how did you fix it?
It's just moving skin around and tightening a scar or doing a bit of liposuction or injecting fat. I mean, it's just, you just look and you chat and you say, well, I can probably do this, and what do you think? And you kind of push the skin this way. And so what's it look like to you looking down? And I mean, it's a little bit of guesstimate, a little bit of experience, but there's just a few little maneuvers you can kind of do.
Talk to me about how far we've come in 20 years then, and how far the technologies and...
I guess we haven't come massively too far,
oh
right?
God,
so
okay.
This operation's been around for a long time. The only difference is now we can do it very efficiently. I mean, the failure rate's maybe 1 in 500, which is super low, so 0.2%. It's safe surgery. There are a few risks. Of course, we talk about them, but like it's just moving skin around the place. As I tell the patient, you come in all nerves and you say, look, I'm just moving skin here, moving skin and fat.
Okay, so the techniques haven't changed. You're just
We're
more efficient.
Better at them. We have a few little things that help us to connect the vessels and stuff that are, percentage chance of working is good. Like the thing about connecting vessels, if you get a cut, you clot and you stop the bleeding, and but we can't afford a clot on these. So the connections have to be perfect to stop the body. You have to fool the body to thinking that we don't need to clot here. And we just come on in techniques and how to do that.
Yeah.
And that, so then it's quicker to stitch them, and it just everything works every time.
And in your opinion then, Jamie, like this is kind of where the sense that I'm getting from you. If a woman is able to kind of get her head around the surgery, is a tissue reconstruction always a better option? So
like that's always asked, and you can't, like, it's just not, there isn't the answer.
Okay.
It's not me, and I don't know, is it worth the sacrifice to me? As in, if you said, if I had, a chest and I had a big divot here, would I want to cut off? I probably wouldn't, because I just accept this. That's personally or what. And so some women, even sure, like I'm pretty sure my mom thinks what I do is weird, because she's like, well, why would women not just go flat and just get over it? In a nice way. Sorry, that sounds terrible. Maybe edit that one out.
No. Well, we will. Well, don't worry. No, I know what you mean on that.
So, but the point being is, like, it's different.
But so your mom was saying, like, just like have one boob
or just like play it real simple, like just get over your cancer, have a simple operation. Why would you go through such a big operation for a breast?
Well, you see,
because I don't make something that makes milk. I don't make something that has sensation, and therefore, so what am I doing?
Well, you're giving a woman back her femininity.
Yeah,
you're giving her woman back her femininity, because if it happened to me, I think, obviously the biggest thing you want is to get over your cancer and be safe and be well for your family and for yourself. But obviously, if you just have one boob, if you can have two, I think I'd opt to have two boobs.
I mean, I'm totally on board with that. That's why I do my job and why I love my job, because, at the end of, when I'm finished with a patient, often we'll give them a hug because it's quite a long journey, and then I discharge them. I'll never see them again. Because the point of own tissue is it ages with you. It doesn't have to be changed. It just is what it is. It's shaped like a breast. It hangs like a breast. It wibbles and wobbles like a breast. Like you have to push it up in a bra.
Yeah.
And it's just not the same with an implant. But they go through a lot. The patients who give tissue, it's a big operation.
Yeah.
There's big scars in their tummy.
Yeah.
And not everyone's up for that. And so maybe you put in an implant, and in a bra they look great with an implant, and in well-chosen swimwear maybe it looks good, and maybe that's just totally easy and enough, and that's their personal decision. So yes, the best breast is your own tissue, like by far and away, like a million times better.
But it depends.
But the same person then has a big scar here.
Yes. Yeah.
Do they want that?
Yeah.
And that's just so personal.
This sort of surgery is being patient-led, which is kind of unusual when it comes to cancer, isn't it? Like it's the
we
woman
acknowledge that in the room.
Yeah, the woman is making a decision
So
really-
I say to the patients, like, the worst case scenario is you do this and you regret it. And I'm looking at a disappointed person across the table because I can't fix that and we won't end amicably. And I'd say in my 1,000 or more than 1,000 of these operations I've done, I think I've 2. And I wouldn't say, I don't think I've fallen out with them, but it's like, yeah, it's a tough consultation because I don't have anything to offer them because I've just done the operation and they have the sequelae of it, which are scars. And they, you have discomfort and scars and things like that. And so, yeah, there's no pressure from me to do it. It's like, give you all the information. This is you decide. If you want to do it, I'm pretty good at it. I can do a good job.
I've had 2 C-sections, so I understand the pain and the kind of the length of time it takes to recover from an abdominal surgery like that. So, and then I'm just putting myself in the frame of mind of somebody who's had a diagnosis as well. So it's a big decision to make.
And if you think C-section scar, you got to multiply that by times 3 or 4. That's the width. Because if you think I got to take the roll off the tummy, so if I just take enough to make a breast, I'll leave extra rolls. So I go the whole way out. You squeeze the tummy till wherever your roll stops.
Right.
And that's where my incision stops, and I throw away half the tummy.
Wow. See, I've got a much bigger arse than I do a tummy. So could you take it off my arse?
Yeah, I can. So there's,
can you?
Yeah. Problem is bum fat's a little bit more solid and thicker. Doesn't make a great breast.
Okay.
So there's another one just above, like the back of the love handles.
Okay.
We call it the lap flap or lumbar artery perforator. And it's quite new. And I recently did a lady from Waterford, did a bilateral one, which is the first in Ireland. There was a single done previously. But yeah.
So bilateral means you did the 2
both
boobs?
sides, yeah.
Both sides for the 2 boobs.
So it was a risk reduction. So she had a genetic risk for cancer.
Okay.
And so she had a tummy tuck, unfortunately. So my normal tissues were gone, and her inner thighs is another option, but they just weren't big enough. And she just had all this extra tissue that the tummy tuck surgeon had not liposucked.
Okay.
So it was just like perfect.
Are the inner I have good inner thighs. I have a lot of fat there. Would that work? No?
Yeah, everyone says you have a lot of fat there, but because nobody likes the little bit of fat that's there, the little bit of loose skin that comes there. But they're never quite as good as you hope for.
So the best is always the tummy.
Best is the tummy. I would say second in the right person is the thighs, and I've a few very happy patients with thigh tissue. And the third one from the back is it's super hard, and I can't do that on my own. Like definitely, I work with a couple of colleagues who do the same microsurgery as me.
Because yes, you have to roll the patient. If you're taking it from the back, then you've got to take it from the back and then turn them over.
Flip them over, you harvest and you disconnect everything. You stitch them up. Meanwhile, your tissues are disconnected, no blood supply. They're on the back table. Turn them over. Breast team then do their mastectomies. I then opened up a C-section scar or a tummy tuck scar and reconnected my vessels, or reconnected the fat, let the breast team finish, and then took like a length of blood vessels as like a jump graft.
Right.
And so now we have this big long vessel length, and so it's like an extension lead, and then you disconnect that and put it in here. So it's a long case, but cool because like it's new and like that's the kick of it. So the enjoyment for me is like the technical. I like doing it, fixing stuff and small. Yeah.
And I'd say it is incredible when you have a woman that comes back into you after a reconstruction, after her radiation, and is feeling like probably a little bit more back to herself, and just the appreciation of womanhood and femininity.
I generally don't give bad news. I'm at the other side of things. I'm going to put you back together. So I'm on this like much more happy curve, which is good. And then in general, the patients are super appreciative, and you develop a relationship with them because you have the adjustment surgery and they come to trust you. And most times when I come to adjustments, they don't really care what I do. They just, say, well, whatever you think, Jamie.
Yeah.
Which is a little bit difficult to consent because you're supposed to tell them what you're doing.
Yeah.
But yeah, it's just super, super nice patient cohort. And then in terms of like how happy they are, the happiest patient I would say is a bad implant that I switch for own tissue, because bad implants can be sore and painful and disruptive to life. Second, happiest patients is person who's gone flat and then has a new reconstruction. And the third happiest patients, which is harsh, and there's loads of patients that are very happy, of course, but in general, is someone who goes from having their own breast to an immediate reconstruction with own tissue. Because it's not the same, and I can't make it the same. Whereas the people who had nothing, their level of improvement is massive. Whereas when you go for your own breast as something that I've made, it's a slight disimprovement on what you had. Does that make sense?
Yeah, get you.
And I try to acknowledge that to patients as well. And certainly if someone comes to me and they have a really good breast, they're like a full C cup, what everyone wants, and like really good cleavage, really good shape, I acknowledge it and say, look, you've got a really good breast. I don't think I can make that.
And if there was somebody who had like a double E cup, right, a woman who has very large breasts, is there a way that you can transport the fat from one breast and use it to?
But it's not fat.
It's breast tissue. Sorry, you can't use the breast tissue from one breast and use it. You know what I mean?
There is in theory a way of doing it, but if you take that, if we do that, then you're taking a big round bit out of this breast to put in there, and then I leave a bit of a divot here.
Yes.
Very hard then to shape that into a good breast. It's not technically a good thing to do.
Okay.
Because you're putting breast tissue now in here in a cancer environment. Historically had cancer, and most people don't want breast cells put back in there.
Yes.
Does that make sense?
Yes, of course. Yeah.
And also, it's very hard to steal a very nice breast out of this and then leave another nice breast in there. So it's technically possible. I've never done it, but I guess you could.
Yeah.
But I don't know why you would, because there's other places.
There's other places. Where is the future of breast reconstruction going? Is there anything kind of happening? Is there anything exciting? Anything in the States that you're reading about that, you know?
Yeah, I mean, there's a couple of things. So one of the things that's happened over the last 10 years is fat grafting. Fat grafting is, instead of me taking a chunk of tissue with blood supply and reconnecting it, it's just sucking out fat. So liposuction from wherever you have excess. And then you inject it in like filler. And you can use that on the face and everywhere else. And you talk about defying aging and stuff like this. You can inject fat as filler. And that's like a perfectly good filler. And there's no foreign bodies.
I never heard
But we can
that.
use this fat and we inject into the breast. So let's say you have your breast reconstruction, looks great, curves great, just a little dimple here, or your radiotherapy classically kills all your native fat. So it's all a bit flattened and thin. Just inject fat. It thins it up, it softens, it looks great. So you get liposuction here, inject it here.
Wow.
Problem is you can't make projection, and you can't make a 3D shape properly with injected fat. You can just fill in like little divots. Bits. And so I guess what I think is going to put me out of business eventually will be someone's going to make like a lab grown scaffold of a breast, and you're going to do the mastectomy, put the scaffold in, 3D matched from the other breast or pre-op matched, put it in, close the skin over it, let everything heal up, your body will grow through it, and then it's like this scaffold system that you can just slowly inject fat into.
Right. Hands up if you have ever been in a situation where you're just not feeling well, maybe you're a little under the weather, maybe you're in a little bit of pain, and you're just thinking to yourself, I need to see somebody right now. We have all been there. And you need to know about the Mater Private's emergency departments in Dublin and Cork. Because when you're under the weather, being seen quickly is really all that matters. And their consultancy-led teams aim to see every patient within 20 minutes of arrival. How good is that? This streamlined approach continues right the way throughout your care. So if you do need a scan, an X-ray, an MRI or an ultrasound, they can get those tests done and the results back to you really quickly, which means your medical team can work out the best treatment plan for you as soon as possible. And that is what it's about, getting that specialist care to you without delay. Now, just a quick note, it is for over 16s only, and do remember to check the opening times. The Mater Private Emergency in Dublin is open every day, 8 to 7, and in Cork, it's Monday to Friday, 8 to 8. So if you're not feeling well and you need specialised medical treatment, remember, you've got the Mater Private Network's emergency department. Get all the details you need and a full list of services at matterprivate.ie. Sorted. Can we talk about the aesthetic side of what you do as well?
Yeah.
And how I suppose that's changed with the onset of social media and trends. Like I certainly know that, and maybe I'm wrong, has the desire for big implants, big inflated boobs, has that kind of moved on a little bit?
Yeah, because the big push is to be fit and healthy, be in the gym, defy aging and sort of longevity and stuff, and huge big E-cups full of silicone doesn't really do that for you because everything stretches. So if you put weight in there, everything has to stretch. So either you put it under the muscle and the implant stays here and the breast falls off the top, which looks wrong after a while, or the whole thing stretches and drops down. So the more weight you put in an implant, the less longevity you get out of it. Most people don't want implants under the muscle, the Kylie Jenner, 400 under the muscle, which is a huge implant, because that, like, your pec muscle is supposed to be doing jobs and it's built to go straight that way. It's not built around a silicone implant. And most people now are quite body conscious, and they just want something that's natural and normal. And, while there are definitely people coming for augmentations, it's very much, you're looking for something really subtle. I'll tell my friends, but only because I've told them that they know. Mm-hmm. Or it's the classic 45-year-old woman, 2 kids, and things have deflated a bit, and they just want a little refill. Yeah. And the idea there is if you put
or in my case, they're so uneven now, because my 2 girls prefer to breastfeed on one side, and I'm just like, oh God.
Yeah. And So like uneven means, we've extra skin on one side. And so then we got to start talking about, are we going to do a lift, or where are we putting the nipples, basically, because one of them's going to be down, one of them's going to be up, and there's just extra skin. And so that comes with scarring. And then you're talking about an uplift or mastopexy.
And why would you go, when you put an implant over the muscle, obviously each individual woman is different, but why would you choose to go over as opposed to under?
Yeah, super highly contested. Lots of people still go under the muscle. Lots of people just go over the muscle. Historically, if you had very little breast tissue, then you didn't really have enough to cover the implant to hide it.
You put it under the muscle.
You put it under the muscle to hide it. And then the muscle covers your cleavage. But in the advent of now taking a bit of fat and injecting some fat to hide the implant, we can now pretty much always do an under the gland or in front of the muscle implant and just inject a bit of fat if needs be.
So you don't see the outline of the implant.
You don't see the outline of the implant. However, we've also shifted from like classically like a 330 implant down to maybe a 150 or 160. And those little implants, they're just filling up what is there. You don't see them. And then they're not pulling much, like the gravitational pull, like the force acting on the breast tissue is much less. And so the longevity of that implant is much better. And most implant providers now, they'll give a lifetime guarantee for rupture. Now, that's not to say they can't rupture, but they're just pretty confident that they're pretty good implants. They're going to last a long time.
Okay.
And so therefore, the limitation of how long your implant will last is how long it looks good.
Yes.
Does that make sense?
Yes. I have been told that my body, my environment is full of microplastics and toxins and everything very recently for this documentary that I did, this Young Forever, Death of Aging. Is there enough research and study done? Like you were putting a strange alien object into your body, and the safety around implants has obviously been, very thoroughly registered,
But has it? I mean, you see how many clinics are just doing stuff. So like, I'm not a huge augmenter, as in I don't have a big practice in it because I'm not super into implants. As in the only implants I use be pretty small, just to give someone back something that they really missed. Okay. So actually I don't have a huge, coming from my reconstructive practice, I'll always err on the bias towards trying to use own tissue or just accepting that we have enough tissue and maybe we just need to reshape. And if someone really needs volume, you can either put an implant in or you could do fat grafting. Problem is fat grafting doesn't quite give you the little bit of projection that people want.
Okay.
So yeah, the microplastics thing, silicone's been around for years. And the problem with saline implants, once you get a tiny rupture, they just empty it. Looks, you get a wash of fluid comes out and the body reabsorbs it. So mostly around the world, it's silicone implants. And the silicone implants are designed to be very resistant to rupture. So everything stays inside. But of course some rupture. And of course some people get silicone migrating into their body from implants. And if that's a concern, you shouldn't be doing it. And that's all part of the chats beforehand. Like nobody needs an augmentation. So it's just, if your wish for an augmentation with the silicone implant is greater than your concern for putting silicone into your body, well, then that's your balance. Again, that's your decision.
What have you learned from women and their bodies, in the work that you do? And what have you learned from women's acceptance or non-acceptance of their bodies? Do you know what I'm trying to say?
Like generally really accepting. Most people are coming to me like functional, as in, I can't wear this dress I used to wear anymore, or all my bras are killing me, or, there's just, I go for a run and there's just so much skin and movement there. I just want them to like, actually, most people that come to me are talking about a functional improvement, and they'd love a cosmetic improvement with it. But I actively don't seek out the social media cohort that wants massive change and that's looking for all the tiny, imperfections. Like I talk about a thing with my patients is like natural asymmetry versus surgical asymmetry. Like a natural breast, they look, there's always a difference. Has to be. They're never perfect. And if they are, I always say it. I'm like, wow, things are really symmetrical. It's going to be really hard to match that. Where surgical asymmetry is so hard, so easy to criticize. Like, well, why do you put that there? Or why is that tighter? Or why is this longer than that? And actually, it's one of those things that most patients are very accepting of surgical asymmetry because, I'm totally honest, and the pictures I show patients are all average. I could show all my best, but I don't show obviously the worst because hopefully I've fixed all them. But the best ones, there's no point. I need a patient that's with me on it and that like accepts that I can only do what I can do. And everyone's coming in looking for that. There's very few that actually come in and are looking for this transformation of perfectness. It's actually not that common. And if you do find them, you kind of have to reel them in and say, look, I don't have it. Like,
Yeah.
and nobody else has it. As
Yeah.
in, I don't think people have something that I don't have. And of course, there's people more skilled or, have certain aspects of their surgical ability that I don't have maybe or something like that. But like on the greater scheme, I do an awful lot of breast. And so I generally tell them, like, honestly, I don't think I should do anything, but I honestly don't think you should go to anyone else because personally, I'm not convinced you'll be happy. And it's sometimes a hard one to say.
Yeah, I can imagine. Wouldn't it be great to get to a place where breast cancer wasn't even a topic for us anymore?
Yeah.
Like we are now flying Artemis 2 to the bloody moon and we still don't have a treatment for breast cancer. We still don't have it.
But we're really good in some of them. As in, lots of times we're doing mastectomies after chemotherapy and they don't find anything left in the breast. So there are specific types of breast cancer that the breast team and the oncologists are doing such amazing work that it's a little bit, God, I can't believe we have to kind of do this now. But the flip side is we're nowhere near telling the patient you had cancer, we're not going to do your surgery, we're going to hope that it's gone. So most patients still want to complete the mastectomy. And then you also have the patients that have like a genetic risk. So the BRCA carriers,
yeah,
this genetic risk that means they're, very high percentage chance likely of getting breast cancer. If you tell them you can go for surgery, just get rid of all the breast tissue and forget about it, or we'll wait for you to get cancer and we're pretty good at curing it, most of them will still want a mastectomy. So we're still a fair while off not operating, but like there's a ton of effort going into it, and it's amazing. It's amazing.
It's exciting times. Yeah. Can I ask you, maybe let's just talk risks for a moment. Like, what are the risks when it comes to breast reconstruction, breast surgery that maybe people don't think about enough or that isn't talked about enough?
So like on the cosmetic side of things, there's always a scar. Anytime we do anything, you got to cut the skin. Okay. And if the main issue with your breast is skin, so it's too large or it's too droopy, I've got to take away a lot of skin. And therefore there's significant scarring around the nipple and straight down. And so there is a very aesthetic, problem that when you look at your breast, you now have a scarred breast. And so one of the big things is making sure someone understands they're swapping a poor shape for a much better shape, but with scars. And scars get better and they heal, but they never go away.
Okay.
Other than that, like realistically, anything without an implant, I can fix most problems. Get an infection, get a bleed, any issues, I can generally fix them. Or if it was a really challenging one and things aren't symmetrical after, it's relatively easy to go back and fix that. And so again, that's a frank discussion. Say, look, if it's a problem, I'm around, I'll fix it. Anytime someone signs up to an operation by themselves, as opposed to being told you got cancer, you got to do something, I always try and tell them the risk of infection can lead to sepsis, could kill you. You get a clot, goes the lungs, could kill you. Same as flying to Australia, you get a clot in your lungs. But if the paradigm shift is that you're deciding what you want, and so you have to take on these risks. It's not me saying you need this. And so I do try to always say that, and it kind of frames it, reminds them that they're choosing this. I find it a kind of a really powerful thing to like just set the tone, because it is surgery. It is still signing up to something.
Yeah.
And so
do you always?
Super rare risk. I don't want to like scare.
Yeah.
Here.
No, but it's good to talk about the risks.
You break your wrist, you could get a clot. You could go to your lung. You could get sepsis from the thing.
Yeah.
Appendectomy, of course. All these things.
Yeah.
They come with the risk. But if you sign up to it, it's a different thing. In your own tissue, like the reconstructions we do with this, there's slightly bigger risks. Is that you can get some chronic pain in the scar. You can. I've had one lady. If she's listening and she knows I know her, she just got a really big bleed afterwards. And fix it. I had to give her blood and stuff like this, but it was a proper big scary bleed. It's the only one I've ever had. And I never used to tell patients that there was a risk of really heavy bleeding. And now, just surgery is always slightly different, which is the great thing about it, but always the unknown.
Do you always operate on a woman when she's lying down, or do you sit her up to kind of see how the boob hangs or sits?
I have a fair idea how they're going to hang now, as in I've done so many. So most of the time I can do them flat. Remember, if I'm stealing your tummy, you don't have a huge amount. I'm going to bend the bed to get you closed. As in the bed will bend at your waist. So that I'm slowly crunching you together to get you to close.
Oh, so you can stitch her back up again.
So that I can get it closed without tension. And
then you have somebody kind of sitting up.
Like 45 degrees, 30 degrees. And then aesthetically, quite often you will ask your anaesthetist, the doctor who's got them asleep, can we go straight up?
Yeah.
And they'll hold the tube, hold the head, the arms are strapped in, and it's almost bolt upright. just for 3 or 4 minutes, just to see how things look, just see where I need to tighten something or see how the stitching looks.
Wow.
So you quite often do that.
Yeah.
Because otherwise,
fascinating.
You're completely reliant on your pre-op markings.
Totally.
Because you do all your drawings when someone's awake, and you talk about what you're going to do and your wish list and the plan. But like you're then just like doing everything based on those markings. If you mess up the markings, and sometimes you do the operation, it doesn't look quite right, and then when you set them up, you realize your markings were good and you're okay, or you realize, oh God, I didn't notice that one's a little bit lower at the start. I should probably tighten it up.
Can I ask you, Jamie, how has this work and your entire career, how has it changed, or has it changed how you see your own health and your own body?
No, I would say I'm a avid disbeliever in worrying about my health.
So you're not a health nut?
Not really. I'm much more healthy now. I'd say in the last 2 years, I randomly got pneumonia about 2 years ago. That kind of scuppered me for a while, and I realized I was probably working too hard and a bit of a wake up call. So I'm more healthy. Like try to go to the gym. Thanks to my wife for forcing me to do it, but makes me feel good. Other than that, not really. I'm thankfully fit and healthy and well. But whatever happens to me, I'm a great believer in whatever happens.
Yeah.
Just do good things and it should be okay.
And you said about walking your dog earlier on, like it is, you make it sound very easy, and you're just kind of, like a lot of the surgeons that I meet, it's just like, yeah, a bit of this, bit of that.
Surgery is easy. It's coming home, juggling kids. And, I thankfully, my wife's a doctor as well. So she kind of understands it, but she like takes the lion's share of, figuring out what to do with school stuff. But you do come home and you got to put in the shift. So you come home, you might operate 12 hours. And you come home and the kids are all awake and the dog's there, not walked. And it's like, right.
Yeah, you have to do bedtime, bath time, story time. Yeah. How do you switch off though? Like, are you good at relaxing?
Not really.
No.
As in, if I have a day off, I feel like I should be doing something. I hate it.
Yeah.
Don't know what to do with myself. I like fixing things and like, manual DIY kind of stuff. COVID was great for me. Because my skill set was not required at all. And so I just built stuff and carpentry and stuff like that.
I love it.
That's kind of,
What's the most rewarding part of the thing that you do? That's an obvious one.
So I have so many patients, that have skin or hand and stuff that just need a fairly simple operation. And you don't really, form a bond with someone on their first visit or whatever. But the breast patients, it's a long visit to start off with. Then they're in for a few days. I'll usually sit down and chat to them for a while. And you just get to know these people. And on the day of discharge, it's just a really nice thing that you've now just sorted that cancer side out, that they can now wear whatever clothes they want. The objective is that they can wear whatever bra, whatever clothes. And, literally, they don't have to think twice about it. And you can pretty much get most people to there. And they're just so appreciative. And it's cool.
And
right.
How, for a woman walking out of the surgery that day, like sending somebody out feeling on top of the world, feeling confident and feeling back to themselves, that must be the greatest feeling in the world. Yeah,
it is. It's cool. Yeah. It's great. And because I'm not dealing with cancer, and like literally it's a happy ending pretty much all the time. There's definitely some challenging ones where we never got quite there. And, we have to kind of leave it by mutual agreement, as in you're like, well, do you want to try something else? Do you want to try something else? And it's always a happy thing. And that's a great part of it. Although I do like my skin cancer patients because they keep coming back, and you know them all by, they're usually 80 or 90, you know them by their first name, and it's, you just chat to them and about the family and stuff. So it's nice. Plus all my cancer patients, I know all about their family.
Yeah.
So we all chat about it and they know about mine.
Yeah.
And so it's just nice.
Yeah. Listen, Jamie, so lovely to chat to you this morning. Thank you so much. Really interesting. And thanks a million for coming into the Are We There Yet studio.
Well, thanks for having me, and it's been enjoyable. Thank you.
Right. Hands up if you have ever been in a situation where you're just not feeling well. Maybe you're a little under the weather. Maybe you're in a little bit of pain, and you're just thinking to yourself, I need to see somebody right now. We have all been there. And you need to know about the Mater Private's emergency departments in Dublin and Cork. Because when you're under the weather, being seen quickly is really all that matters. And their consultancy-led teams aim to see every patient within 20 minutes of arrival. How good is that? This streamlined approach continues right the way throughout your care. So if you do need a scan, an X-ray, an MRI or an ultrasound, they can get those tests done and the results back to you really quickly, which means your medical team can work out the best treatment plan for you as soon as possible. And that is what it's about, getting that specialist care to you without delay. Now, just a quick note, it is for over 16s only, and do remember to check the opening times. The Mater Private Emergency in Dublin is open every day, 8 to 7, and in Cork, it's Monday to Friday, 8 to 8. So if you're not feeling well and you need specialised medical treatment, remember, you've got the Mater Private Network's emergency department. Get all the details you need and a full list of services at matterprivate.ie. Sorted. You've been listening to Are We There Yet? Hosted by me, Kathryn Thomas. Visual design and video edit by Stephen King O'Farrell and Connor Daly. Music courtesy of Audio Network. Series producer Paul McGregor and executive producer Sasha Hamrogue. New episodes of Are We There Yet? Are released every Tuesday morning wherever you get your podcasts, and you can also watch this episode along on YouTube. Are We There Yet? with Kathryn Thomas is an Onyx original.